It's a pleasure to introduce a wonderful colleague, Simon de Lusignan from Oxford, who's going to talk about the English data infrastructure that we've been working with. And Simon's going to do a magic act of 19 slides in 5 minutes.
It won't be magic, but we'll be there. But we'll have to keep saying, next slide, please. Marvelous. So that's me. I'm a practicing GP in a practice that's a microcosm of the stresses and strains of primary care, and I'm a professor of primary care and clinical informatics at Oxford. And within that, I'm the director of the Royal College of GPs Research and Surveillance Centre, about which I'll say more. Next slide, please. I'm going to briefly talk in really 4 areas. And there's these header slides in between, so you can see how far I'm through. If we can go on to the next slide, I thought it was worth mentioning why the UK is such a good place for research, disease surveillance, because we have practices and patients are willing to share data. We were computerized in the 1980s. We have a registration-based system, not NHS number in Scotland, but a unique identifier nonetheless. We were financially incentivized to do chronic disease management that involved coding. We have laboratory links, electronic prescribing, and I think it's a big step forward. We have a machine processable clinical terminology, SNOMED CT. Next slide, please. And so now I'm just going to tell you a little bit about the history of the RSC, if I can whiz on to the next slide, please. So the RSC is one of Europe's oldest Sentinel systems. The person top right started in 1957, some data collection. It's his G.I. Watson, who was a president of the Royal College of GPs. And in 1967, the college started a Birmingham research unit, which I'll return to later, and was involved in surveillance. The picture of Douglas Fleming, my predecessor, and we've seen phenomenal growth through the pandemic, and we've grown from 100 practice network when average practice size was under 4,000 to over 19 million patients in contemporary extraction. We divide our network into 2 parts, which also I'll return to: a primary care Sentinel cohort that does virology and serology sampling, plus syndromic surveillance general practices. And we've been involved in producing a thing called the weekly return for the last 55 years, in fact 56, but let's move on to the next slide. This is just a squint at what our weekly return looks like. You can sign up for it online, and the example on the right is the weekly different viruses that have been contemporarily circulating. The pinky one is COVID, unsurprisingly. The greeny one is influenza B. The grey one, RSV. We'll move on. The scope of the RSC and the data sharing agreement we have our practices is be a squire and share data for squire purposes, which are surveillance, quality improvement, research and education. The RSC has worked closely with UKHSA and its predecessor bodies. We perhaps differ from other data networks in that we know who our practices are, and if they code something unusual, we can contact them. And within our primary care Sentinel cohort, we have practices that collect samples for virology and serology. And we always want a relationship with our practices about sort of, what's in it for me if you're a practice, and that we provide sort of feedback on quality, particularly data quality, and things that will help our practice work better. Next slide, please. I'll just give you a very brief overview of our cohort, and if we can have next slide, please. And on the left is our primary care Sentinel cohort. It's just crossed 1,000 practices, and within this group of practices, the ones that collect virology samples. We have routes where healthcare professionals take them in surgery, but also a route where we can send swabs to people's homes. Our sero surveillance involves healthcare assistants or patients prior to a blood test appointment being asked, do you mind if we take an extra blood bottle? You won't get a result from it, but it'll be used to monitor how effective vaccines are in population immunity to infectious disease. And then we have our syndromic surveillance general practices who are on a daily extract. This is a fantastic arrangement with EMIS, where we get very, very contemporary data that support UKHSA syndromic surveillance. Next slide, please. This is just showing our age sex profiles, very similar. Next slide, please. This is just showing over a sort of year period how we can monitor flu vaccine uptake, COVID first dose, and COVID second dose, the sort of exposure data we see. Next slide, please. And then this is the sort of outcome data we can look at, so we can link at an individual level to hospitalization, to intensive care use, and death in and out of hospital. Next slide, please. I'm just finally going to whiz through some longitudinal data, and this is data back from 1957 to now. Next slide, please. And there are three groups. There was initial data collected on spreadsheets, then the Birmingham Research Unit BREW database, and then our current database we call the Real World Evidence database. Have the next slide, please. This gives you from 1967 to 2022 how there was an awful lot of influenza-like illness about, and shows the introduction of influenza vaccines over 65. LAIV is the squirt up the nose influenza vaccine to children, and then adjuvanted vaccines for older people, and how ILI has declined over that period. The next slide, please. Shows similar association of the introduction of MMR on measles, mumps, and rubella. Next slide, please. And in summary, if I have the next slide. We're proud of being a bottom-up professional-led network. We utilize national health system IT and infrastructure. We've had enormous expansion across the network, with many more practices and patients feeling happy about sharing data. We've got this unique 55-year history, and we consider ourselves an underused resource, that we've had considerable challenges in scaling. And if I just have my final acknowledgement slide, I'd just like to thank, the next slide, I'd just like to thank patients and practices for data sharing. This is absolutely key to what we've done. Many funders, particularly UKHSA and Wellcome Trust for Longitudinal Data Study, and the great help we have from software companies, particularly EMIS, over pseudonymized data extract. Thank you.
Great, thanks very much indeed, Simon. Absolutely fantastic resource.